Welcome to GECO session. As you know, GECO is hosted by the Gastro Foundation in collaboration with Project iEcho based at the University of New Mexico. These sessions are held every Wednesday at 4:30 p.m. The chat will be open for questions, so please feel free to post your questions when the talks are in progress. Tonight's theme is IBD and colorectal cancer, and we've got 3 presentations. The first one is going to be done by our own fellow, Innocent Francis. So he's going to go through a recently published paper of a population-based study of colorectal cancer in an IBD cohort. Unfortunately, I am double booked, so I'm going to have to hand over to Dr. Ernst Fredericks, who really needs no introduction to this group. So he'll be able to facilitate the meeting and take questions going forward. I apologize for the fact that I won't be able to be part of the meeting, but I still believe that we've got very good talks, and I hope they encourage a lot of discussion. So without any further ado, Innocent, if you're ready, please share your screen.
Thank you. All right, thank you, Prof. Thanks so much for the opportunity. Once again, I'm Francis Innocent, so I'll be doing a journal review that was recently published on IBD and colorectal cancer. It's a population-based study. And just to say, this was a study that was published in American Journal of Gastroenterology in 2022. That was in November, and the study was based in the UK.
Innocent, sorry to interrupt. We don't see your slides.
You're not seeing my slide?
No. Just hold on.
I can see it.
Are you sure, Prof? Maybe it's your side?
I can see the slides.
I can see them, Innocent. Carry on.
All right, then. Oh, it's okay. So this is, it was published in the American Journal of Gastroenterology in November 2022. It was titled Inflammatory Bowel Disease Associated Colorectal Cancer Epidemiology and Outcomes, an English population-based study. Just to say that we all know that IBD is a big gun now. Years back, it was said to be of low prevalence in the African subcontinent, but if you look at it, it has been skyrocketing over the years, and for now, we are really a big gun to reckon with in terms of IBD. One of the big issues that comes with IBD is colon cancer. There are guidelines on screening for colon cancer, but I think that this review also helps us understand more about IBD and colon cancer and the outcome of colon cancer in IBD. And it was compared to non-IBD colon cancer cases. So what they did in this study was that it was a study population data that they used to, what they compared, they look at all those that were diagnosed with colon cancer. They use the ICD-10 code for that, and then they also look at those that had IBD as well, and they use the ICD-10 code, and they now tally, pulling out all those with colon cancer. And what they did in this method was that they now, after having the big pool of all those with colon cancer, they now separated out those with IBD and then those without IBD, and they now have the profile for both. So that was the method that was used in getting this data. And it was gotten from the National Health Service colorectal cancer data repository that was in the UK. And so look at those without prior diagnosis with IBD and those with IBD, and that is spanned from 2005 up to 2018. In terms of the IBD, just to point out that they look at Crohn's disease and the UC and IBD unclassified, and then the IBD cholangitis. The unfortunate part about this, their study, is that the cholangitis did not segregate between a bacterial cholangitis and a PSC itself. So, but then if you look at the data proper, you would understand that the profile of patient and the outcome seems to correlate very much with the PSC that is seen in a IBD. So we then have these two groups, and they look at the outcomes up to 2 years time. So in terms of statistics, so it was a descriptive analysis that was performed to examine the difference between the IBD and the non-IBD group. And they also had a sub-analysis that was also performed to assess their characteristics as well, looking at the non-IBD and the IBD group as well. They also look at the probability of an event taking place, and they use the adjusted logistic regression models to calculate the odds of you having a disease, and also the stage of the disease as well. They also look at emergency presentation, and they look at the 90-day post-operative mortality outcomes, and they compare these two parameters both for the IBD and then the non-IBD cases. And this is just to look at the patient characteristics. So they look at the median age, and you see that for the IBD cases, there seems to be younger at 66 years average, and then the non-IBD being about 72 in terms of the average. But if you look at it more closely, those with IBD with cholangitis, the average age was 54.5 in terms of the age. And again, that correlates well with the fact that, yes, if you're having a PSC, IBD with PSC, the risk of colon cancer is higher with them and occur at a young age compared to those without a PSC, if you're going to compare within IBD itself. In terms of age-wise as well, sex-wise, we look at the male prevalence compared to the female. So male was more, but again, if you look at it closely, you will see that those with cholangitis, the percentage of male among them was quite high. Again, we also understand that IBD and PSC seems to occur more commonly in the male as compared to the female. So this seems to also correlate well as well. They also look at the socioeconomic status as well. There was no significant difference between the two groups in this. And then interestingly, they look at the stage of the colorectal cancer. So for those who are either stage 1 to stage 4, and they look at among those with IBD, how many of them had stage 1, and there was no real difference between IBD and non-IBD. But if you look at the subtypes of them, interestingly, stage 1 was commoner among those with a PSC, and not just stage 1, but most of them were more with those with a PSC. So even if you look at those with stage 2 as well, if you come to PSC group, they were actually more as well and up here. So it just correlates well with it. And then again, they still look at part of their characteristics. They look at the site of the tumor as well. They look at either right colon or left colon. And if you look at the right colon side, you will see that for those with IBD, about 37.4% of them had right colon, and against 31.4%. Again, this correlates well in IBD that occurs more commonly on the right side as compared to the left side. And then they also look at the route of the diagnosis. And what is interesting here is that for those with IBD, that many of them presented that in the emergency department, and one begin to ask why it was so. Interestingly, we know that the IBD symptoms seems to correlate, or they look more like a cancer type as well. So there's no big difference between the cancer symptoms and then the IBD when it comes to having bloody stool and sometimes diarrhea. So many of them will have, because of the fact that, yes, these IBD cases, sometimes you think it's a flare, and then they are being referred to the emergency, and in the process they got diagnosed with IBD. Again, the UK system had a system where they said if you have any red flag, they are being referred to emergency for emergency colonoscopy. So that itself seems to possibly will have facilitated this process where you have more of them being diagnosed in the emergency as compared to to those with non-IBD from 25 to 16.7. And then they also look at synchronous tumors as well. And just to say that, just to define that term properly. So if you're diagnosed with colon cancer now and within 6 months you had another colon cancer again, that's a synchronous one. But if you have outside of the 6 months time, then that is a metachronous cancer. So if you look at this group, if you compare those with IBD and non-IBD, it is almost double. So 3.2 and then 1.6%. And that tells you that, well, if you have somebody with IBD with a colon cancer, the risk of having another colon cancer is high. And I think this is very, very informative when it comes to your choice of management. If you are going to just treat it locally or just going to do a segmental resection, or what are you going to do? Knowing full well that the risk of you going to have another cancer becomes very high if you have IBD and cancer. And then again, this also is seen in the group with the metachronous as well. Again, it plays out the same way, that the risk is higher among those with IBD as well. So if you compare between these two, again, it's almost going to become double again, though not exactly double, then it's quite significant in this group as well in terms of metachronous. Again, this if you look at it as well, if you come all the way to also those with cholangitis, it is quite significant as well, that they too, they still have that higher risk as well, and that also should guide us on our management as well in terms of your choice of treatment if you are going to do anything. And then they look at the mode of resection in them. So they look at major one, and then they look at minor one. When I'm talking about a major one, looking at doing it is total loss of colectomy. So they look at for those with IBD, so this is the IBD and then the non-IBD. So those with IBD, it's about 72% had major resection, and then a 69.9 had a non-major for the, a major for the non-IBD. Then if you come to the minor one, I was a bit surprised what they have to do, but they did a minor resection, just a localized area of about 4.6 for the ones with IBD and 6.4 for the ones without IBD. We do expect a higher percentage for those with non-IBD, but I was still just querying why they have to go this route for them to do their procedure in terms of knowing the roots behind that, but that we don't have that info why that was done. So this is just part of it as well. So those who are total colectomy, again, for those with IBD, about 36.3%, and then non-IBD is about 2.9. So it was quite significant, that very lot. I will know that, yes, because of the fact that we understood the issue with metachronous and synchronous tumors, the option will have been, the best option will have been to go for total colectomy in this our group. If you look at it, I wonder quite a large chunk of their patients had segmental resection for cancer. I'm not quite sure again why they have to go this pathway, but one will have expected that for those with IBD, that if you have a cancer, one will have possibly opted for a total. But again, I think with a more modernized way now of making diagnosis for very early cancer, possibly they will have seen a very early one, and then they opted to go, but that they did not explain why that was it. Again, they also look at the stage of diagnosis and the route to diagnosis for patients with IBD by colonoscopy interval. So look at those who had 1 year screening, and then those who had alternate year, and then those who had 3 years and 5 years, and others. So interestingly, for those who had annual screening, and they were able to pick about 24.4% at stage 1. And this is very, very important, because we want to pick very early cancer as against making a late diagnosis. And for those who were on 5 early screening, they were able to only pick 11.1% of the cancer. And this should begin to ring some bells in one's mind and in the ears as well. Perhaps our screening mode might need to be altered. Do we really need to wait for 5 years? We know that, yes, in terms of screening, that has been classified into those who are low risk, intermediate, and then those who are high risk. And then for those who are low risk, that, yes, they have 5 yearly screening, and then those who are intermediate is 3 yearly, and then those who are high risk is yearly screening. But I think this is very, very important, knowing, seeing what happens, say that we're able to pick more if we do a yearly screening. Perhaps we begin to think otherwise. And this trend seems to also continue. But then if you come to the late presentation of it, for those that annual screening was able to pick 27, and we now see that late presentation were picked up those that had 5-yearly screening, and so just the trend was just increasing from the 27 going to 29. So again, that tells us that, well, perhaps we might be missing some of the colon cancers if we seems to be having a late screening of 5 years, as this their study seems to allude. And they also look at the survival estimate at 3 years interval. So just to say that this black dot is for those non-IBD, and then this is the IBD case. So for those that had stage 1 cancer, what they found in their study was that, yes, there was no significant difference in terms of their survival. So yes, it's all the same. But as we begin to move towards a late stage, we are seeing that while those with IBD begin to come down, the number was coming down. This is about like less than 90. Those non-IBD ones, they have more survival even after the 2 years. And then as you come down more, you begin to see separating out more that, yes, for those at stage 3, that IBD cases, survival begin to decrease. This is 70%, while for non-IBD is still 80, and it trends. And this tends to allude to the fact that, again, that the IBD, colorectal cancer in IBD patients seems to have a different terms of the progression, and then the mortality seems to be higher. The outcome is not as good as those without IBD. Again, this is just to look at the figures properly, that yes, for stage 1, this is IBD and non-IBD, their survival rate. So stage 1 is about the same. But as you come down to stage 2, this is 88 and 94. As you come down again to stage 4, yes, stage 3, you're seeing 70, 82, and stage 4 is 36 and 51. So the mortality is higher among those with IBD as compared to the non-IBD patient. And also look at the logistic regression in terms of looking at the outcome, and they compare again in terms of their stages, both the stage 3 and stage 4, and then the emergency diagnosis, and they now compare among the IBD subtypes. So if you look at IBD, that okay, no IBD is taken as 1. So the odds of you going to present late, if you see non-IBD is 1. If you compare the subtypes between Crohn's and UC and the PSC, so to say, what it shows is that those with they don't seem to present late as compared to the non-IBD, and this is possibly because of the screening process, so or less than 1. So what this alludes is that the screening process that we are having, regular screening, seems to be quite helpful as compared to non-IBD that don't have a regular screening as IBD. They do have their guideline, but not as regular in terms of compared to IBD itself. So, and that is very good. That is quite helpful for us, and I think we are happy with that. And if you look at the emergency diagnosis as well, if we say non-IBD reference is 1, look at how many of them came to the emergency or were diagnosed in an emergency situation. So mostly Crohn's seems to be the one that colorectal cancer in Crohn's disease seems to be the one with the highest presentation in terms of emergency diagnosis as compared to the others. Interestingly, PSC is less. Again, this is because PSC falls into the category of high risk, and they go the yearly screening. So maybe that is why they did not present in emergency with the cancer, because it seems to pick them up way earlier as compared to the other subtypes of the IBD. And then again, they look at the mortality at 90-day post surgery, and what they observe is that if we say non-IBD is taken as reference 1, the mortality for this group of patients for IBD cases seems to be on the higher side. And surprisingly, in their own cohort, what they found was that, again, Crohn's disease with colon cancer, the mortality seems to be higher. I think I'm not too surprised, knowing full well that Crohn's disease itself is a big gun, might have some other complications with it, fistulas and other things, and therefore, possibly that would have impacted the whole thing as well for them. But on a general note, all the IBD subtypes, and it seems to have a higher mortality at 90 days as compared to the non-IBD being a reference point for that. And then here again, we also look at they look at again, we look at the subtypes, and what we're looking at. Sorry, this seems to be blocking my way. Right here, this. Just trying to get the one on top of it, but thanks. So I was looking at the Cox regression analysis for death within 2 years of colorectal diagnosis. So if you look at that as well, look at the subtypes of the IBD, and what you find is that the hazard ratio for it again is higher among the IBD. So if you look at the non-IBD, if you look at non-IBD as one, all of them seems to be higher. So again, it's still alluded to the fact that it's more aggressive and that the mortality is higher among them. Again, if you look at the comorbidity score, it shows that that if you have more comorbidities, then the outcome seems to even be poorer. Again, that is quite supportive of the fact that yes, with higher comorbidities, the risk of death is higher among them. So this is just the last slide to summarize what the study shows. So in this study, so they look at 390 cases of colorectal cancer, and among this cohort, about 500 of them were IBD, and they look from, again, just summarize from 2005 to 2018. And the key findings that they got from this study was that IBD cases with cancer seems to be younger than the non-IBD ones, and that more of their IBD patients were presented in the emergency department. They were diagnosed as emergencies. And again, interestingly, we have more of the right colon cancer for IBD, so 37 versus 34%. And then again, more synchronous compared to the non-IBD, it's about double. Again, like I did emphasize last time that in the previous slide that this is very, very informative in terms of your choice of surgery. If you're going to do a segmental resection, we're going to do a total resection. But I think that seeing this one, we almost all know what we need to do. And then metachronous cancer is also quite higher in them compared to the non-IBD as well. Again, in their study, they also noted that about 67% of the patients with IBD and cholangitis, they had total colectomy. Again, they are more aggressive, and it's expected once you have it, you want to just move the colon as well. And yeah, this is just a brief study that they did over there. Thanks so much. Yeah, over to you back, Mesh.
Thank you, Innocent. We've gone a bit over time, so we will go straight ahead with the next presentation, which is that of Leo. And Dr. Leolin Katsidzira is well known to this platform. He has trained at UCT and he's done his certificate of gastro there. Subsequent to that, he has also obtained a PhD, I believe, in colorectal cancer genetic modeling. And he is currently working at the University of Zimbabwe. And Leo will talk to us about IBD-associated CRC and what we should do on the African continent. Thank you, Leo. You can go.
Thank you, Ernest, for this, for the kind introduction. I will just share my screen there and we'll go right ahead. So I'm really going to be talking about screening for colorectal cancer in patients with IBD in Africa. And what I'm going to focus on very, very briefly, a few perspectives on what I actually think we should be doing given our, and I always go back whenever I talk about IBD and whenever I talk about colon cancer to Dennis Beckett's original hypothesis, which was based on a low incidence of certain diseases amongst the African population, i.e. colon cancer, inflammatory bowel disease, diverticular colitis, and so forth. And this really has formed the foundation of what we know to date about the influence of environmental risk factors on disease. But despite having said this, and when you look at the literature, IBD remains relatively uncommon in sub-Saharan Africa. In this review by Hodges and Paul Kelly, I think they picked less than 200 cases of IBD, published cases of IBD. And similarly, in this one, I think this was published in the South African Journal of Medicine. There were 210 cases up to 2020. And in Zimbabwe, where I'm currently practicing, at that point, there were 7 published cases of IBD. But obviously, there's always the talk that sometimes if you don't see a disease, but the disease will certainly see you, which just speaks to often undiagnosed cases being out there in the population. But when you look at the way this disease is really uncommon and we don't have that many case numbers, I think the first point I want to make is that comprehensive screening for colon cancer across sub-Saharan Africa is actually feasible, even with the current endoscopy resources. When you actually just look at the low case numbers, and in addition, when one thinks that if you want to screen for colon cancer in general in our population, you are going to have to use targeted screening because population-based screening is clearly not an option. And amongst the targeted screening, you should be including patients with inflammatory bowel disease because they are certainly at a higher risk than the general population. So the first point is, I think there is no room for saying we can't screen for colon cancer in IBD patients in sub-Saharan Africa. Then the second point I want to make, which speaks back to the first slide on Dennis Beckett, is that the risk factors of IBD and those of colon cancer are generally similar and broadly and perhaps inappropriately can be classified as being related to increasing westernization. And this has been covered by the previous speaker. We do know that amongst the risks of getting colon cancer in those patients who have IBD are long-standing disease, people with extensive disease pancolitis, if there are strictures, and if there is a strong family history of colon cancer, and goes without saying, patients with PSC. So when you look at the fact that IBD and colon cancer share many risk factors, and both are emerging in sub-Saharan Africa, you should then realize that, from my perspective, that all patients with IBD, even the ones with limited disease, are actually at a higher risk than the general population because they have been exposed to more or less the same similar risk factors. Thus, for me, I think you should actually consider screening everyone who has IBD for colon cancer. What can only differ is the frequency of screening. So when you look at sub-Saharan Africa, someone with a pancolitis and severe disease should probably be screened according to the guidelines. But when you look at someone who has limited proctitis or left-sided disease, I think one should screen them at least once in their disease course, maybe at about 45 years, 50 years, simply because putatively they should be at a higher risk of colorectal cancer than the general population for whom there is no current screening programs available. So when one goes back to the guidelines, one thing that comes up frequently is that patients should be screened about 8 to 10 years after disease onset. And if they have PSC, they should be screened at diagnosis. The question that would come back to me is, should this apply in Africa? I've just put a graph there of an analysis we have done on patients that we have seen with IBD here in Zimbabwe. And the median time to diagnosis was 2.2 years. The longest was 22 years. And when you look at this, you can see that quite a number of patients, 100, those are months. Time to diagnosis is in months. And when you look at it, you actually realize that there are quite a number of patients who are getting diagnosed at more than 20 years. This is at around the 10-year mark. To me, what this means is that we should actually be thinking of dysplasia at diagnosis rather than later on in the disease course. Obviously, the mere existence of extensive inflammation makes characterization of dysplasia rather difficult and tricky at diagnosis, but the thought should cross our minds that if I see a patient who has been symptomatic for many years, there is a possibility that other than the IBD that I'm very happy that I have made a diagnosis on, that this patient may already have dysplasia. Thus, one would need to keep a very close watch. Then I will just briefly go through the fundamentals of dysplasia detection. And to me, one should be able to do quite a lot with a standard high definition colonoscope. It is best done when there's quiescent disease and involves really just washing and careful inspection of the mucosa with targeted biopsies of suspicious abnormalities or sites of prior dysplasia. I think one can use enhanced dysplasia detection techniques. And I keep going back to the point that I made very early on, that if you are saying the numbers of patients with IBD are low, then it shouldn't be that much of additional work if we are going to screen and, where possible, use some of these enhanced detection techniques. Then obviously one should take targeted biopsies of any suspicious or mucosal abnormalities, then also non-targeted biopsies. And these would help with assessing histologic activity other than just assessing for dysplasia. And those are really the sort of suspicious lesions one would be looking for, from the standard polypoid lesions. And some could really be just standard polyps that we have all been looking at, to non-polypoid lesions. And then there's always invisible dysplasia that would be seen by the blind biopsies that we've been talking about. Thank you very much. I made this short, and thank you, Ernest.
Thank you, Leo, for that succinct overview. We have a few minutes for questions. So I'm going to open this for questioning. If there are any questions, please just unmute yourself and go right ahead and ask the question.
I'm not sure whether I'm getting through to you, Ernest. Am I there?
Yeah, you are. You can speak, James. You can go.
Thank you for those two talks. I'm just not clear in my own mind whether we are at a stage where we can actually
James,
reasonably stratify patients' risk in terms of, from the patient's aspect, he will come to you, let's say he's 30 years old, and he's been symptomatic for 10 years, and you diagnose him to have mild to moderate pancolitis. And he hears from you his risks for the present and for the future. And so he asks you, he says, now, why do you not rather do my colectomy now? Why wait until I have to get cancer before you operate on me? And how do we then answer that patient? Do we have enough tools to give him a clear road ahead guideline?
I suppose I can take that. For me, I think whilst there is a risk, the way I would answer it is, whilst there is a risk of dysplasia in IBD, the risk is actually low. So I think we should still watch the patient and monitor, but offering any intervention for such a low risk would probably be unwarranted.
Any other questions? Can I just ask Leo at this point? You know, we've previously talked about chemo prevention, and you know, you well established data about 5-ASA and whether it was a confounder or not. Would you give all your patients 5-ASA with ulcerative colitis at this point? And what are your thoughts on aspirin as a preventative measure?
Thanks. There is some data of aspirin in Lynch syndrome and so forth, but I don't think, I haven't actually checked whether there is any data for use of aspirin as chemo prevention in IBD. And I think when you look at the risk of colon cancer in IBD, you look at the studies, the risk seems to have been falling. And I think part of it is just improved treatment with an increasing number having well-controlled disease as opposed to the past. So I suppose that rather than one focusing specifically on chemo prevention, it should generally be just treatment of IBD as prevention of long-term complications such as colon cancer. And obviously, the long-term goal should be to get the most effective treatments to the population.
Yeah, can I just add at this point that the hazard ratio has been shown in the study that Innocent presented, that it was increased in the general population in spite of the biologic era. Because I mean, it was from 2005 to 2018 where biologics have been widely used in the UK. And we were hoping that, you know, by just controlling the inflammation, we probably will have better outcomes with regards not just to the IBD, but also to colon cancer as a preventative measure. We haven't really seen that now, looking at that study. Your thoughts on biologics, maybe as a tool?
I think there I will go with you, Ernst, and I will probably need to look again over the paper Innocent presented.
Okay, if there are no other questions, can we ask our final speaker for the day to get ready? It is Dr. Chukwudike. I hope I'm saying this out right. And he will present an actual case of IBD and colorectal cancer, and he's speaking from Nigeria. The floor is yours, sir.
Thank you. Please, can you share my slide from there?
Cheryl?
So I'm asking if you could share my slide from there.
Yeah, can you share them? Can you load them?
I sent it to her. Sorry, I couldn't load it here.
All right, okay.
Your slides is not arrived with me yet.
I sent it to you.
It's not here yet. I've checked my email now.
Wow. Not sure. My laptop just went off. I thought I sent it.
I haven't received anything since 4 o'clock.
Okay, I've just found the slides. I can share it from my side.
Okay, thanks, Karen.
Okay.
There's a question in the chat box in the meantime, Ernest.
Can you see the slides?
Yes, just put it in
Yeah.
presentation mode, Karen.
Yeah, I can see it. Okay. Can I go on?
Yeah.
Yes, just tell me when you'd like me to advance.
Yeah, I think you can go on and we will address the questions at the end. Okay.
Okay. Yeah. Thank you so much for the opportunity to make this presentation. Okay, I'm Dr. Chukwudike from the University of Calabar Teaching Hospital, Nigeria. I'm a consultant gastroenterologist. So just as a way to kick off, this is University of Calabar, where the case was diagnosed. University of Calabar Teaching Hospital came into existence in the year 1979. It took over from the first hospital, public hospital in Nigeria, named Margaret Ekpo Hospital. The bed space is 780, and Calabar is a tourist center. Please, can you go over to the next slide? I present this. Mr. UC is a 68-year-old gentleman, a retired civil servant who's a Nigerian and lives in Cross River State, Nigeria. Next slide. He presented with recurrent diarrhea of about 5 years, recurrent passage of blood in stool of 5 years, recurrent abdominal pain, and weight loss, both of 1 year. Next slide. So Mr. UCE presented to our facility about 2 months ago with frequent stooling. Because it was watery in consistency, he described it about 4 to 6 episodes per day. And a few months thereafter, he noticed passage of blood in stool, which was bright red with presence of mucus. The quantity of blood in stool was poorly characterized by the patient, but with history of occasional dizziness, but no loss of consciousness or reduction in urine output. Next slide. So for the above complaint, he sought medical help at Lagos, Nigeria, where he was initially before coming down to Calabar. Part of what was done for him was colonoscopy, and he was diagnosed with ulcerative colitis and had some medication that gave him some relief at that time. The patient could not follow up his clinic visit and medical checkup. Rather, he resorted to some herbal medication. Then 4 years later, he developed abdominal pain and weight loss. Abdominal pain was at the lower quadrant. He said it was dull, but occasionally colicky. And thereafter, he began to notice weight loss, which was progressive, and with associated recurrent low-grade fever and night sweats. Next slide. He volunteered history of anorexia, but he never had nausea or vomiting. No hematemesis or melena, no jaundice, pruritus, or passage of pale colored stool. He had joint pains, but no mouth ulcers. Next slide. So the patient did not volunteer any other chronic medical conditions. No family history of similar illness. He does not drink alcohol or tobacco in any form. He has no known drug allergy or food allergy. Next slide. Next slide. Okay, so on examination, we met this chronically ill-looking elderly man. He was pale but non-icteric. Abdominal examination was not remarkable. His pulse was normal. Blood pressure was 100/70 millimeters of mercury. Next slide. So at that time, our working the diagnosis was inflammatory bowel disease. We were also trying to rule out colorectal cancer. He was scheduled to do the following investigations. We booked him for colonoscopy to do full blood count, erythrocyte segmentation rate, serum urea and creatinine. He was also supposed to do serum albumin, stool MCS, and fecal calprotectin. Next slide. So he did colonoscopy. Colonoscopy showed marked mucosal inflammation and ulcers. It also showed loss of vascularity in most segments of the colon with mucosal friability. He had spontaneous and contact bleeding. There was thickening of the descending colon with suspicious mucosa. Next slide. So we had multiple biopsies done for him every 10 cm, like colon at 10, from the cecum down to the rectum, and sent the specimens for histology. Endoscopy diagnosis was, at that time, was severe pan-ulcerative colitis to rule out colorectal malignancy. So for endoscopy, his Mayo endoscopy score was greater than 3. So we put him as severe endoscopic disease. And if you look at from what we found here, if you look at the ulcerative colitis endoscopy index of severity, it was greater than 5. We couldn't tag the full value because at that point we didn't do serum calprotectin and C-reactive protein. So these are some mucosal changes in this patient. You could see the severe inflammation. Down there, he didn't have the vascular markings. Mucosa was very friable and with much contact bleeding. Next slide. Just show a few of this slide. Next slide. Okay, next slide. So the histological report came up and showed a severe colonic inflammation. The sections of the descending colon showed a tumor composed of malignant epithelial cells growing tall glands with papillary fonts. It also had disorganized tall columnar cells with hyperchromatic features and coarsely clumped chromatin. The rest of the tissue showed severe colitis and atypicality. So the diagnosis was infiltrative adenocarcinoma, well differentiated, and at least ASLA cola B1. Next slide. So we tried to do other investigation for him, serum and creatinine. The result was essentially normal. Next slide. The full blood count was not so much remarkable, except mild anemia that was 29%. VC was 29.1%. Next slide. The ESR for this patient was 69 millimeters per first hour, and fecal calprotectin was not done yet. The patient has not paid for that test. Next slide. So stool MCS revealed no ova or X or parasite. No stool pathogen was isolated. We are looking at all these tests in preparation for his treatment. Fasting plasma glucose was 5.2 millimole, was normal. Chest X-ray was normal. No abnormality was detected. Next slide. So diagnosis at that time was pan-ulcerative colitis with colorectal cancer. So which basically colon cancer. So we put the patient on tab prednisolone 40 milligram daily. We commenced it to taper it for about approximately 2 to 3 months. And we commenced him on tab mesalamine 1 gram BD until we review him. He was also on a tab fesolate 200 milligram BD at that time. We asked for, considering the result from histology, we asked the patient to do serum calcium embryonic antigen, abdominal ultrasound scan, liver function test, and prepare him for referral to general surgeon and oncologic team for review. And then we continue to follow him up on outpatient in the clinic. Next slide. The calcium embryonic antigen came up, was marginally elevated. Liver function test showed the low albumin, which was just low marginal. Other parameters were normal. Next slide. So abdominal ultrasound was done. Later we did abdominal CT scan. This abdominal CT scan, it showed the liver span was 16.5 cm and smooth in outline. It also showed predominant homogeneous parenchyma enhancement, harboring multiple round, small sized, hypodense lesions with smooth outline measuring 0.9 by 9 cm, as shown here. Most of them were at the segment 8, 5, and 4B, and segment 7 respectively. The lesions showed no enhancement post-contrast, and the intrahepatic biliary ducts and common bile ducts were normal. Next slide. So there was loop of bowel in the descending column with smooth diffuse wall thickness and luminal narrowing. Other visualized bowel loops were normal in caliber, wall thickness, and peristalsis. Other organs were normal. So in conclusion, the abdominal CT scan actually showed inflammatory, also concluded like inflammatory bowel disease with metastasis to the liver. Next. So we try to do hepatitis B panel for the patient, looking at the liver CT scan finding from the liver, anti-hepatitis C evaluation, and HIV test. All of them were not remarkable. Next slide. So our definitive diagnosis for this patient was severe pan-ulcerative colitis complicated by colon cancer with metastasis to the liver. If you look at the finding we have here, we are looking at the ulcerative colitis, colorectal cancer grade or stage of ASLA cola D2. Initially, it was from histology was ASLA cola D1, but when we did comprehensive evaluation for him, we are looking at the patient with ASLA cola D2. Next slide. So, looking at this patient, we would have commenced him on biologic at that time, but patient did not have funds. I tried to go for that. We commenced him on tab-mesalamine, 1 gram BD, and referred him to oncologists for review, and then for outpatient follow-up in the clinic, and then for the patient to repeat colonoscopy in 2 to 3 months later. So this patient is now on follow-up in our clinic. Next slide. Thank you. I can now take a question and discussion from this.
Yeah, quite an interesting case. I must say, you know, and probably not something very uncommon that we would find in the African continent, even with us. So can I maybe ask some of the other colleagues that are on here, if you see a patient known with UC, now present with colorectal cancer and without metastases. If it's without metastases, what would be your first priority? First to treat the UC or do total colectomy? How do people think about this? And anyone can just put up his hand and just answer, please.
Prof, I wanted to say something on that.
Yes.
In fact, that was one of my first concerns when I saw the UC and the colon cancer. I was wondering, because for me, my option would have been to do a colectomy. That would have my option. So I wanted to ask our presenter actually why they opted to go for prednisone when they were suspecting the colon cancer already and not opted for colectomy. Considering the fact that yes, prednisone will have otherwise even worsened it, but again, even with or without prednisone, I think my option would be to do a colectomy if there's no metastasis, then that would have been my first option in terms of treatment. Yeah.
Okay, so looking at what I presented, when we did colonoscopy for the patient and saw he had a severe pan-ulcerative colitis, so we took the biopsy for histology. Histological report doesn't come out quite early. It took about 3 weeks for the result to come out. So we didn't know that it was going to be colorectal cancer actually. So it was when the result came out. By then, it was already on the slot. So we quickly referred him to surgeons and for evaluation. So if I had seen him, if I had gotten a histological report quite early, what would be the topmost on my mind would be to send him immediately for colorectal. But finally, when we completed his evaluation, because funds were some issues, when we completed evaluation doing abdominal CT scan, and we now saw that even there is already metastasis even to the liver. So our attention now move also to oncologists managing him with the general surgeon at this point.
Can I ask maybe some of the senior colleagues, Wayne Simmons, Noni Ramanathe, what did you guys do in this particular instance?
Good afternoon, everyone. I think, fortunately here, we don't see this entity or this combination presenting commonly. I can't think of a case that we've had this consternation with, but the thinking I would offer is that we would also, opt for the side of colectomy in this case, if the cancer was confirmed. I assume we have histology and it's proven and the patient has a flare. We would manage him, emergently as we would any patient with an acute severe UC, for instance. But if the histology came back and there was, dysplastic lesion or malignant lesion, that would be one that we would refer for colectomy. Salvaging the patient, and then, with stoma, with salvage surgery, and then, considering, the rectal sump at a later stage, and surveying that at a later stage. But, that would be my thinking.
Yeah. Any other thoughts? Maybe new adjuvant and debulking prior to surgery. James, what are your thoughts on this?
Dreadful disease and dreadful conundrum, but this particular patient obviously should have had his colectomy 10 years ago. And, in pancolitis, the risk is clearly of malignancy is multifocal. So you pay attention to one focus, the cancer comes from another focus. So again, we're trying to turn this into a medical condition, but it really is, I suppose, a well-timed surgical intervention for these patients, because we just don't have the wherewithal to do the crystal ball. That will come, I'm sure, as the genetic modeling improves, but right now, we just don't have the crystal ball. So I would think we have a low threshold for discussion with our surgical colleagues. We all know the pros and cons and risks and et cetera, but here's a good example of how complicated it can suddenly become. And obviously that cancer has been there for years and years already. So should it have been picked up initially by better biopsies, by chromoendoscopy, by a CT scan at the time? Who knows? You can perhaps guide us there, Ernest, but it just remains a very, very difficult problem to handle, I must say.
Yeah, certainly. Let's hope that we, that our patients generally don't end up here. I think there was this lack of follow-up that happened, and maybe some of our patients also don't turn up for their routine appointments at times, and even for the screening colonoscopies. I can certainly tell from previous experience, past experience, that is certainly the case. Are there any other questions, maybe for the other presenters, that we can ask? There was a question in the chat box for Leo that says, was there a notice in an increased incidence of IBD and CRC in HIV positive patients? Did you see anything like that, Leo? Are you still here? Leo doesn't seem to be present. certainly the advent of HIV, we have seen quite a number of patients with HIV and especially with ulcerative colitis. Crohn's to a lesser extent. I have not yet personally, seen patients with colorectal cancer in that particular scenario. I don't know whether anyone has. Maybe for our colleagues from the state sector, have you come across this? I certainly also don't think that the screening and other recommendations for HIV positive patients should be different than for the routine IBD care. So, our patients usually, after a certain period of time gets regular screening as sort of according to the guidelines. So I haven't seen why I just going through the questions here.
Can I say something?
Yeah, go ahead.
Yeah, exactly. That was in our environment, even the IBD, where most times people don't think the IBD is there. But now we are beginning to see frequent number of patients with IBD. And like with colorectal cancer, not very common. This is the first time we are seeing something like that. That was why we were just raising our index of suspicion and sending him for histology, thinking malignancy, but not a very common thing. The only reason why we consider colorectal malignancy was the way the descending colon shows the mucosa was not looking too good, it was so suspicious. So, but finally it came out to be malignancy. So I think it's a tragedy in Africa, the late presentation, because this patient was seen about 5 years ago and in another city where he did colonoscopy. And he was asked to continue his come for follow-up. He didn't go for follow-up again. 5 years down the line, he now returned to Calabar, where we now with rectal bleeding, weight loss, night sweat, and all that. And when we did this, and we found him with this. So it's a big challenge, and we need to raise our index of suspicion for this case. Thank you.
Are there any other points that we can ponder at this point?
Yeah. Good afternoon, everyone. Can you hear me?
Yes, Nani, go ahead, speak.
Yeah, I'm just wondering, well, from the safety point of view, would we have done the full-length colonoscopy in this patient with pancolitis, or would we have maybe just done the rectal biopsies or go to the sigmoid and then induce remission, and then after a month go and do a full-length, hoping that the mucosa is well healed? Because I'm just scared that going through a full-length colonoscopy with somebody with myocolitis of grade 3, right, is quite risky. I don't know. What's your comment?
Then you certainly would have missed the cancer.
Yeah.
Correct.
Yeah.
But do you get my point or my concern?
I get it. I mean, it doesn't appear that he had acute severe UC. He only had moderate to severe ulcerative colitis. So in that instance, it is if you feel it's safe enough to complete the procedure, I think that should be fine. It's only in acute severe UC that we will use other modalities for scoring, etc., and then decide on treatment rather than do a full colonoscopy. We just want to confirm the diagnosis and exclude CMV. So that's really what the crux of the thing is, or that would be my approach to the problem.
Okay. Yeah, thanks. Yeah.
Okay. So if there are no other questions, it just leaves me to thank everyone, especially the speakers, Innocent, Leo, and Dr. Chukwudike. Thanks very much for your contribution. It's much appreciated. I also at this point want to thank iEcho of the University of New Mexico and iEcho India for the help with this. And this presentation will be available, the recording of it will be available on the Gastro Foundation website. And we also want to thank the Gastro Foundation for the efforts of bringing this educational material to all of us. And we want to thank our sponsors, especially And don't forget, next week we have endoscopy as a topic. So future, there will be communication in that regard. Just what's out on for your emails. And yeah, and thank you for all of you who have been present. We certainly appreciate, and enjoy the rest of the night.
Thank you.
Bye.
Thanks.